Otto Kernberg and I had switched places. I don't know. I'm very glad to be doing this talk, though. It's an area that interests me. I have no conflicts of interest, just the usual ones around dependency, aggression, and intimacy. And they're none of your business, actually. Here's what I'm going to try to do. I'm going to say a word or two about how I got interested in BPD. Why does treating BPD matter to anyone outside this relatively small club? Explain a bit about how BPD and early adversity contribute to treatment resistance in depression and other disorders, and then say some things about shared elements across therapies for suicidal borderline patients. So, how I got interested in BPD. So about 200 blocks north of here, I was in medical school at one time at P&S, and I was doing a rotation on a psychiatry unit at the old Psychiatric Institute that had a similar spectacular view, except what you looked down on was the George Washington Bridge. And I was told during that rotation, oh, there's a woman in that room, go take a history. And so I went in, and the room looked out over the George Washington Bridge, and it wasn't too different from that view in the slide. And I asked her, what was going on, and she said to me, I wanted to die, so I jumped off the George Washington Bridge. And the story began there, and it went on in four-part harmony, like an equivalent of Arlo Guthrie's Alice's Restaurant, if you have any familiarity with that piece, all about her life and how awful it was, and being the first person to survive jumping off the George Washington Bridge. I was enthralled. I was in despair. I was in agony. I was in love. I was completely gut-hooked by the experience. And I followed her on that unit, a long-term inpatient unit, as a medical student, for some time, at some distance from until she was discharged. So then I go off to residency at Dartmouth, and this paper comes out by a young fella named Gunderson in the American Journal that talks about borderline personality. And I said, oh, I remember that patient I saw in medical school. This reminds me of what she was struggling with. And, I go off to Austin Riggs, where actually a lot of the early papers on the borderline syndrome were written, and fell into an opportunity to do some empirical research, which was interesting. But I really wanted to figure out something about how do you work with these patients? What is it? Why do I feel so lost and inept all the time? And what is it my supervisors seem to know that I haven't got a clue about? And so I tried the best I could to pay attention, and that actually led to this notion of an alliance-based intervention for suicide that I spoke about here last year with a case example that really spends a lot of time talking about carefully negotiating the alliance, and then proceeds by paying attention to cycles of rupture and repair that mobilize both the positive and the angry negative elements of treatment. But that's not what today is about. Years later, it's like 25 years later, I'm doing a talk out in California. And I told the story of the woman who jumped off the George Washington Bridge. By the way, I had been warned that at this grand rounds, we have an attending who's going to kill you. She does it to everybody. Don't take it personally. Sure enough, her hand shoots up as soon as I'm finished. And she says, did that patient you talked about, did she go to Haight-Ashbury after? And I said, I hadn't thought about it in many years, but of course, she went to Haight-Ashbury. And she said, well, I treated her too. She made 2 careers. So I did not get slammed. In fact, I made a friend by virtue of that coincidence 25 years later. So, but why on earth does BPD matter to anyone who's not in our small club? We think it's very important, but a lot of the world turns their noses up at it, and that's an important issue for us. And I don't need to tell you the things that are on the next couple of slides. BPD is frequent. It's especially frequent in people who are seeking treatment. It's associated with significant mortality, not to mention morbidity. And compared to other more popular high-profile disorders like a bipolar disorder, there's more comorbidity with BPD, more suicide attempts, more suicidal ideation, worse social functioning, and more substance use comorbidity. But it matters in another way. It matters because psychiatry and other disciplines have been very busy shifting models. And we know about this. I mean, I know this just from coming year after year, and there's a lot more brain imaging on the screen than there was 5 years ago when this meeting started. And there's something about, and my boss, Andrew Gerber at Riggs, who's an fMRI researcher, says, his view as an fMRI researcher is that it's not that different from phrenology, except done on the inside in terms of the size of the bumps. But there is much to learn from MRIs and fMRIs. But the shift has been to a biomedical model, or what Steve Sharfstein calls the bio model of disorders. And that's largely replaced the biopsychosocial model. And that's significant as a shift, partly because it's associated with three false beliefs that just get glibly taken as if they're the case, when the evidence is pointing in the other direction. And I'm going to give you a quick survey of that evidence. The three false assumptions are that genes equal disease, that patients present with single disorders that respond to single evidence-based treatments, and that the best treatments are pills. These are some of the assumptions that go along with the bio model. So first of all, false belief one, that genes equal disease. I picked this slide especially because it also matches the DNA that's on the rug. The double-coiled helix that comes along with this room. Massive, wonderful, important psychiatric genomic studies searching for the genes. We were promised in 2003, when the human genome was decoded, that in a very short period of time we would unravel the genetic underpinnings of depression, of schizophrenia. We'd find, borderline personality too. And what have we found? We have found that the genetics of mental disorders is extraordinarily complex. And it's not genes, it's gene-by-environment interaction. That's what's important. The environment becomes far more important, the biomedical model teaches us, than we had realized. By the way, gene by environment in English means biopsychosocial, but that's another story. There's been a search for biomarkers that has been relentless. Some have likened it to the search for the Holy Grail. But we don't find biomarkers. What we do find is what I think of as an enviromarker. Early adverse experiences are extremely important. They profoundly, powerfully predict one or more mental disorders, substance use disorders, medical disorders, and even early death. It's extraordinarily important, but because it's environmental, if you look at a treatment algorithm, rarely does it include, does the patient have experiences of early adversity? It's all as if people are simply receptor sites for molecules, and that's something we need to be cautious about. And I think the science is really fascinating, but even in translational research in monkeys, for example, we're learning fascinating things that tell us about the importance of the environment. If you separate baby monkeys from their mothers, so they're traumatized in terrible ways, we learn that what changes in their DNA from that traumatic experience of adversity is that there's massive methylation of their DNA. So for those who aren't familiar with it, not that I'm an expert in it, if you methylate DNA, it collapses down and it can't be available for transcription. I think of it as like on your cell phone, changing apps. When trauma happens, you shut off the life is pretty good app, I'll run this DNA, and you hit the OK crisis mode app, and it changes things in profound ways. And so every cell, every bit of DNA in every cell in the body is subject to methylation, to shift of apps in the cells. And this is in liver cells, it's in brain cells, it's in sperm and in eggs. That's how Lamarck was right and Darwin was wrong. It's the way that intergenerational transmission occurs. Yes, the DNA comes from the parents, but is it the methylated or the demethylated DNA? Anyway, the reason I'm taking you on this monkey tale is partly just to tell you that what's interesting to me is what we're learning about the way that demethylation occurs. It doesn't occur from socializing with other monkeys. It actually seems to happen during periods of quiet reappraisal, when these traumatized monkeys are put in their cage alone and cued by the memory of the lost mother, the scent on a cloth. And it makes me think about, are we talking about grief work? Are we talking about mourning? is there's something very powerful about these human experiences that actually work on that kind of a molecular level around methylation and demethylation. Can't tell you for sure, can only raise questions. I feel a little guilty doing it since that's what our president likes to do, but I think it's worth knowing about this kind of research. The second false belief, that patients present with single disorders that respond to specific evidence-based treatments. Not so much. If we look at, for example, major depression and the STAR-D study, not only do we find that there are frequent failures of treatment to our evidence-based treatments, but in Wisniewski's reanalysis of the STAR-D data, she found that actually 78% of the people who present for treatment of depression have the kind of comorbid conditions or suicidal ideation that would lead them to be excluded from study. So of the 100 people who present for the randomized trial, 78 get sent home. We do our study on 22. Of the 22, there's 11 in each cell. When it comes to meds, 8 get better out of the 11 from the med, the active agent. 6 get better from placebo because 75% of the benefit is placebo. 2 out of the original 100 respond. I mean, what are we doing? It's important. It's crucial evidence. It's important that we know it. But if we put it in perspective, there are serious questions about the power of our evidence and what it actually means, not to mention that a lot of our evidence is of statistical significance rather than clinical meaningfulness. And this large group of people who would have been excluded from randomized trials of therapies and medications had comorbid disorders, and this group was less likely to tolerate medications. They had lower rates of response, remission. It's a serious problem. So, the average clinician who says, gee, I tried that treatment that I read about in the journal, but it seems like my patients are sicker than the ones they studied, is right, nearly 4 times out of 5. And we know that from the Collaborative Longitudinal Personality Disorders study that it's personality disorders especially that contribute to these kinds of troubles in Axis 1, so-called Axis 1 disorders. That personality disorders adversely affected the outcome of depression, caused persistent functional impairment, extensive treatment utilization, significant suicide risk. Skottel's quote in the 2011 paper is that BPD robustly predicted the persistence of major depression despite treatment. He says assessment of personality disorders is essential in patients with depression. You all know what the most frequent personality disorder diagnosis was in DSM-4, right? Sabes thinking. We'll just defer it. And so there's the danger that we are missing massive things in the large part of the field that is interested in what used to be Axis 1. We are virtually invisible. And yet it's crucially important in terms of why people are not getting better. It's not all, but it's a significant chunk of the comorbidity. Now, then there's this whole question of psychiatric diagnosis and the way we're doing that. And I've really enjoyed seeing the slides of the neurobiology, but it's always the same circuitry, whatever conference I go to. It's amygdala, it's hippocampus, it's anterior cingulate, it's dorsolateral prefrontal cortex, orbitofrontal cortex, ventral striatum. It's the same circuitry, and the secret of psychiatry is we use the same 75 medications for all disorders. Sometimes starting with number 1, sometimes starting with number 50. And Caspi noticed this. Caspi noticed patients have multiple disorders. We're using a connectome that overlaps for all disorders. The medications are the same. And he did an interesting thing. He studied 1,000 patients from New Zealand who had been followed in terms of all their symptoms for 20 years. And he did a factor analysis. His hypothesis was that he would find 3 factors underlying all psychiatric disorders: externalizing disorders, internalizing disorders, and thought disorders. And he cranked up the machine, he ran the analysis, and there was some weak support for the 3-factor model. And then in his post hoc moment, he said, okay, I'll tell you what, statistical program, you tell me, how many factors are there? There was 1. He calls it P for psychopathology. And this P it's comparable to IQ. If you have high IQ, you're likely to do well in a cognitive task. If you have low IQ, you're probably going to not do well. Well, if you have high P, you're probably going to have one or more disorders. If you have low P, you're probably not going to. And P becomes a function of adult adversity, family history, developmental history, compromised brain development. There are important things going on about this. It's what's behind the RDoC effort and that kind of thing. And so here's what it's teaching us. It's teaching us the diagnosis itself, including BPD, is a surface representation. So we know the Matterhorn when we see it, just as we know depression or schizophrenia. But the Matterhorn isn't caused by genes for Matterhorn. The shape we recognize is a surface representation due to unseen forces like P, tectonic plates, erosion. And we are so far in our diagnostic system from being able to recognize this that we're still thinking in discrete categories as if they were meaningful, and they keep overlapping and patients keep having multiple ones. Third false belief is that the best treatments are pills. This is an actual fMRI of a patient getting polypharmacy. We've overestimated medications. The randomized trial exclusion criteria means that the drugs only work for a minority of the patients studied. Antidepressants are overestimated by a third in their efficacy. 75% of their effect is placebo effect. They're not that good. And one of the things that's emerged in the field that's of interest to me is this phenomenon of treatment resistance across disorders. Because, and what we know about it is that patients often don't get better, even with our evidence-based treatments, because of several factors, including early adversity as a significant predictor of that, and comorbidity of two flavors, axis 1 disorders and especially personality disorders, as in Scodell's borderline personality disorder, robustly predicting the persistence of depression. The majority of patients have multiple comorbid disorders. There are high failure rates for our evidence-based treatments. Treatment resistance is emerging as a significant problem. BPD contributes to treatment resistance, but it doesn't get diagnosed. And except for our small club, there aren't that many people who pay attention to it. This is a serious kind of public health problem. We need to broaden our focus from one on BPD alone. And you hear it in the talks, Now we're talking about BPD plus PTSD, and we're noticing the comorbidities when we try to talk about how two of them had substance use disorders, and we're recognizing that BPD rarely occurs as a pure sample. We need to be paying attention to BPD as a comorbid disorder that contributes to treatment resistance in a wide range of disorders, especially treatment-resistant major depressive disorder. And of course, when it comes to personality disorders, psychotherapy is the mainstay of treatment in one form or another. But psychiatrists, my guild, we're doing less treatment. Most people know the Mojtabai and Olfson study, a decline from over a 10-year period from about 44% of office visits involving therapy to under 29% in 2004, 2005. It didn't get better since then, I can assure you, over the last dozen years or so. So this is the problem. The incidence of BPD is high. Suicide and treatment resistance follow it. We have an alphabet soup of treatments. GPM, MBT, TFP, CBT. It reminds me of when my mother used to make me the Campbell's alphabet soup, and I would see all these things on my spoon. But few clinicians achieve proficiency in even one of these treatments. Also, social policies issues play a role, but it's getting late, so I'm not going to spend a lot of time on this. But BPD is also largely ignored by insurance companies. I don't need to tell you that, despite the fact that it plays such a powerful role in why people don't get better. Well, in 2015, the Institute of Medicine issued a report on psychosocial interventions for mental and substance use disorders. They were worried that, particularly with the parity law, hey, we're going to have to start covering more psychosocial treatment in Medicare and Medicaid. What do we need to start thinking about a quality assurance framework for this? And a lot of people have complained about this report in various ways. What I think is a stroke of genius in it is the call for us to stop the circular firing squad, to stop competing between CBT, DBT, TFP, and instead to search for non-specific elements, their name for common factors, associated with outcome. They did not want to prioritize one school of therapy over another. They said, what we're interested in is what works that actually makes a difference. Because, all of our meds and therapies have not ticked the needle very much on suicide risk and that sort of thing. What are the non-specific elements? Yes, there are specific elements, but what are the non-specific elements we could start with? And so, with colleagues in the group for the advancement of psychiatry, actually I was there at that meeting yesterday, we decided, well, let's take a look across the evidence-based treatments for suicidal borderline patients, and let's see what we learn. And so we looked at dialectical behavior therapy, schema therapy, cognitive behavioral therapy, which had little less robust evidence for its efficacy with suicidal borderlines, good psychiatric management. I put it in the behavioral column, but as you know, it probably fits somewhat astride both. We looked at mentalization-based therapy among the psychodynamic ones, transference-focused, and this alliance-based intervention for suicide that also has a lower evidence level. And we formed an expert consensus panel of people who were knowledgeable about one or more of the forms of therapy. These are the people who are on it. Beth Brodsky was our DBT expert. You can see Eve Callagore, Frank Yeomans, some people you know quite well. Were in this group, but should we pay any attention to a group of experts who do something, and because they're not, it's not rigorous and it's not science and there's no evidence. And so I just want to tell you what your cardiologist is doing to you. Of the 2,711 cardiology practice guidelines, the percentage that meet the highest level of evidence, multiple randomized controlled trials and meta-analyses, is 11%. And fully 48% of what your cardiologist does for you is based on expert consensus. So just to keep it in context, there is a place for paying attention to that. Now, I'm not going to spend a lot of time on these slides. This audience hardly needs it. Behavioral therapies rectify deficits in skills needed to tolerate intense affects and correct distorted thinking. You know what they do. I don't need to repeat that. And the psychodynamic therapies view suicide as related to unconscious mental processes that drive intense and unbearable affects. There are differences in how MBT conceptualizes it from an attachment perspective compared to TFP and the object relations perspective. But again, we've been talking about that quite a bit the last couple of days. I won't spend more time. And good psychiatric management is an integrated therapy that has a focus on psychoeducation, reality testing, life beyond the therapy with an active therapist. We've been hearing about this again. And so I'm not going to spend much time on this because I'll get back to it later, but these are the 6 common factors or shared elements that came from our discussions, this expert consensus panel reviewing the literature. But we said, well, okay, that's not the end. Now what we have to do is we have to see who else has approached this problem. And we looked at the others who have explored this issue, which included the Boston Suicide Study Group with its candidate interventions. The late Terry Maltzberger was involved in that, Elsa Roningstam. Paul Link's Common Principles, Anthony Bateman's Common Characteristics. And we found that when we then looked at these other formulations of common factors, there were substantial areas of agreement, but a few areas of disagreement. Here's where the major differences were. The Boston group and Anthony Bateman really emphasized attending to the patient's affect. We in the GAP group thought, well, that's kind of implied. We don't disagree. We just didn't pull it out as separate. Same thing about Paul Link's and Anthony Bateman's emphasis on connecting patients' actions and with the feelings that they're having. Well, we thought that was part of the technique, but good point. Paul Link's differentiated potentially lethal from non-lethal suicidal behaviors. That's interesting. We could not achieve agreement about that, primarily because Beth Brodsky, representing the DBT perspective, said, no, that's just not how we look at it. They're gateway behaviors. And what we wound up with was adding one more shared element or common factor, and these are the 7. And I'll spend a moment just going over these to give you a sense of what they are. Whether we're doing DBT, TFP, we are spending time negotiating a frame for treatment. Sometimes when I'm teaching beginning fellows about psychotherapy, I tell them, and this may be more true for dynamic than other therapies, but I say we really only have 2 tools: empathy and our frame. And establishing that frame was something that is true in different ways across all the different treatments. Also, each and every treatment, in somewhat different ways, recognized and insisted on the patient having responsibilities within the therapy. Sometimes it's to do homework. Sometimes it's to be on time and say what comes to mind. There's always an emphasis on you have responsibilities here, and if we're going to do this, you need to meet your responsibilities. There's always the provision to the therapist of some roadmap, of a conceptual framework for understanding and intervening, so that when the going gets tough and you feel lost and confused, you have some hope that you'll be able to decide, well, what I ought to do now is keep calm and carry on and say, boy, you really sound mad at me, or whatever, whatever is the appropriate thing at that moment. The use of the therapeutic relationship to engage and address suicide actively and explicitly. It's in the room and it's in the relationship. In different ways, it always becomes something that is not, put out there. It's always something that we talk about that has meaning. I think of it as the handle we put on the teacup. It allows us to pick up the issue. Changes it from just a symptom to an interpersonal event that we have to pay attention to. And the one we added is the one in the bold print, which is attending to the patient's affect and connecting it with actions. We were persuaded by the other groups that, okay, we left that one out, we'll add that to our other 6. And prioritizing suicide is a topic to address. It's never the second most important thing. If it's active, it's always the most important. And finally, provision of support for the therapist. That therapist has a tough time operating alone, and the support can come in different forms. It can be manual adherence groups. It can be supervision groups, countertransference support groups. It can be the manual itself, or with occasional consultation, but all of the forms of treatment provided support for the therapist. So those were the combined common factors across all the expert panels that we reviewed. This is actually the reference for the paper, and I want to just say a word before I stop about, we have a lot of fun rooting for our team. Where I live in Massachusetts, the fact that I'm a Yankee fan is noted duly by my neighbors because it's a Red Sox nation, and we like our team to win. But that competition between schools is not really helpful. It's a circular firing squad. We can spend all of our time fighting with one another instead of speaking to the larger world about the importance of borderline personality disorder and treatments that attend to personality characteristics. So I think an advantage of a common factors approach is reduced competition between schools of therapy. It also allows therapists from multiple schools to speak in a common voice to the larger field. We were just hearing about exposure and response prevention. There's a lot of people who recognize that as a core element of what works in treatment. And I completely buy that. And that works whether you're doing virtual reality exposure and response prevention or whether you're doing exposure in the transference and response prevention sitting with the feelings in the transference. I think that we need less time arguing about whether exposure and response prevention is a central shared element than figuring out how do we do it. It also, in the same effort that GPM is trying to make, defines teachable skills for clinicians short of full mastery of a technique. You can easily teach common factors to people as part of a residency or a psychology training program. And then they have a basic toolkit. They have some basic sense. And when people learn about this and they see that it becomes useful, some percentage of clinicians usually get hooked. And they say, hey, that's actually interesting to me. I think I want to learn more about DBT. Or I think I want to learn more about this TFP thing. And people then wind up having a gateway to deepen their proficiency. It's also consistent with the Institute of Medicine interest in the non-specific elements across therapies that can help us begin to shape therapies of the future so that they're really, in whatever model we use, most likely to be effective. And I think we have reason to believe that it would improve outcomes in patients with borderline personality disorder and comorbid conditions, rather than just ignoring the borderline personality disorder altogether. So it's a kind of a big tent approach that I'm talking about. That's what I favor. And for those of you, if anybody's a psychiatrist, I hope that you know about the big tent that we have in the American Psychiatric Association to make psychotherapy great again within psychiatry. Well, it never stopped being great. Well, this is a political discussion, but this big tent is called the APA Psychotherapy Caucus, which is now 2 or 3 years old and grew from 10 members to about 300 now, and we're meeting at the annual meeting at the APA. If you're planning to be there, I'd love to have you. If you're interested in joining, all I need is an email from you, and good idea to let me know if you're an APA member. But I think we need to form a big tent, put away the circular firing squad, speak to the larger field, teach them that gene by environment means biopsychosocial, and treatments must include a psychosocial component that's prominent. Thank you. Valerie.
Congratulations. But I, in my funny little way, I kind of question why. When we talk about people with borderline personality disorder, persistent functional impairment, they're in pain, they don't sleep. Why don't we have cross-discipline? Why isn't somebody here from the sleep world telling us about sleep research? I do this on my own, and I like borderline people respond to the way people talk to them. So I look at sound research, sound processing. Why aren't we doing cross-discipline work, not just in the little narrow field of borderline, but looking at the symptoms of borderline about which we really don't know anything? I just wonder about that.
Yeah, well.
I just wonder about that.
Yeah, well, I was going to say that's a terrific question, but it wasn't really a question. It's kind of a.
I'm an advocate.
Yes, it was kind of an advocacy statement, and you were telling Marianne what you want on the program next year, and so I got that. But you're also making a fundamentally important point, which is although we try to peel out the data and measurable things, functional impairment, and that it's about human suffering. It's about awful misery and people living in despair. I completely agree, and we live in a world in which much of that has to be measurable to attract scientific notice.
I just wanted to ask your opinion about how we can achieve a balance between the benefits of empiricism and evidence-based treatments, because they really revolutionized the awareness community and the kind of attitudes for this prognosis, even though you wrote a longitudinal study long ago that said it was a good prognosis diagnosis. With the fact that it takes a long time to get any benefits to the bedside from the bench. And Peter Vonnegut once quoted that it takes 19 years to get something from the lab to the bedside. How do we balance the tension? Because, when someone says here, oh, we should research this, it takes a year to write the grant and maybe a year to get the money, and then it just
You won't get the money. You won't get
the money, and then just
You won't get the money. You won't get the money. Yeah. No, it's a huge question. Well, let me try to answer in two ways. Big and terrific question. I in no way do I mean to put down the importance of empirical research. I think it guides us powerfully, but We have been pouring money for 25 years since George Bush I declared the decade of the brain. For 25 years, we have been pouring money into the biomedical models, research into the brain, imaging, and psychiatric genomics. I think it's fascinating. I try to follow what I can. Can anyone in this room name a single clinical benefit that has emerged from those 25 years of study? We have very nice pictures. We know a lot about psychiatric genetics, that it's gene by environment, not just genes. I don't think there's a single finding. Yet the NIMH has pushed all of its funding into brain research and not into the kind of clinical trials research that would allow us to have a stepladder to build on what works with actual patients. In no way do I want to put down empirical research. I mean, the slides I'm trying to pick out are, hey, for those who follow the research and adhere to the biomedical model, the evidence isn't all supporting it. And in fact, there's recently been 2 or 3 papers, sorry I don't have the references with me, and the guy's got an unusual name, Iotides, but beginning to raise questions about when and how do we look at the big idea and re-examine whether the big idea that's guiding the field, that's guiding the nation, is delivering results in the way we want to. That's starting to come up, and I think we need to put money into research where even as Peter Fonagy says, let's at least get to the point where we can get the money and know things. I think empirical research is terrific, but the work we do is as much or more as science.
In relation to that P factor that you were talking about in your science part,
Well, CASPI did not look at CASPI did not look at the P psychopathology factor specifically in relation to personality disorder. I think that that it's the same as everything else. If it isn't the Matterhorn, it's the Mont Blanc. That we see it and we call it that. We are very sensitive to the components of personality disorders in the work that we do, but it's probably part of the same psychopathology factor, because if you look at the things that are associated with it, like early adverse experiences, family troubles, that it looks like it's the same kinds of things that underlie personality disorders. There's no axis 1 and axis 2 in the P factor. And that's why even though it's a very awkward trial, the RDoC direction is very awkward. It's hard for us to link to it. There's a new thing called the high top that I'm still learning about as a diagnostic system. But we need to do something better than have an axis 1 and an axis 2 and act as if there are separate disorders. There's a huge overlap. If you have early adverse experiences, you're more likely to get PTSD. You're more likely to get depression. You're more likely to drink. There aren't separate disorders caused by the environment and caused by genes. It's gene by environment. So time to go home pretty soon, I think. Thank you.